So our next speaker is Dr. Maran from the Medical University of South Carolina.
Thank you all. So I'm going to be talking about a case where, honestly, Shockwave saved the day for me. These are my disclosures. So this is a 91-year-old who came in with his 87-year-old wife to discuss PCI options. Patient has been having worsening dyspnea on exertion and lower extremity edema. Past medical history is significant just for AFib, asthma, tobacco abuse. Had an echo and a coronary calcium score in a 91-year-old. Okay, and the calcium score was 1,600, so subsequently had a left heart cath. And these were his meds. And the patient was initially, before doing the workup time, was managing very well, doing very well. The frailty score was 3, but now he's not able to do anything, and the wife who depends on him is not able to, they're just not able to cope. This is his EKG, creatinine is 1.2. He's a very kind of fragile looking person, and this was the baseline EKG, and the heart rate was around 45 to 47 beats per minute in atrial fibrillation. And this is his echo. He has moderate aortic stenosis, also in the same setting. This is his coronary angiogram. You can see a non-dominant right coronary artery, and this is his left system. And for whatever reason, the outside cardiologist took only cranie pictures of this, and all I could make out was, okay, there's possibly a tight left main and there's a LAD lesion. And this is all I had to start with. And by the time this guy came to me in clinic, his heart rate is now, initially was in the 47, now it's in the 44s, and he's more fragile. I'm like, okay, we are not sending you home from clinic. We are going to the hospital to take care of this the next day. And the factors to consider in this case is very poor visualization of the bifurcation, need for atherectomy in a heavily calcified vessel with a heart rate of 45 beats per minute. And Kate mentioned I don't like to put temporary pacemakers. There's moderate AS, normal EF, but extremely frail person with very little reserve to lean back on. So I decided, even though EF was normal, I decided to go with a single impeller support because, as I said, there's no reserve. If something dissects, I'm going to be in trouble. So 6N French Teramo sheath is what I use when I use single axis impeller, and a 7 French EBU. This femoral angiogram doesn't do justice to what I had to suffer because the aorta was going from right to left to right to left. Had to use Amplat super stiff wire to get the JR4 up to cross the LV, and by which time it took us about 25 minutes to get the impeller up. And this is a Friday afternoon case. And then I tried to get my EBU 375 through the single axis. It's just not reaching because it's just too much tortuosity and it's just not reaching. There are too many kink points, and my angiogram is no better than the outside hospital angiogram. I'm not able to get good pictures. And as I said, very tight knuckles. And then somehow we try to get the guide in, and I'm like, okay, this is going to be easy. This is going to move on very quickly from now onwards. And I wire the circumflex, and I am not able to wire the LAD. And it's another 20 minutes into the case. I'm not able to wire the LAD. I've taken a dual lumen catheter. I've tried to put an IVUS in place, and by which time I realized this guide is not working. I have 0 guide support, and my equipment was getting kinked outside because of the dual. So in a fully heparinized patient, we decided we are going to get a separate second femoral axis, and the single axis plan was not working. So we got 7 French axis, got a 7 French EBU from the left femoral artery, and now we have some support. But even then, I am not getting into the LAD. We put an IVUS in place, trying to visualize maybe I can, get something in, and I will do IVUS guided wiring of the LAD, but not working. Then at this time, no, I can't go back. So at this time, I decided I'm going to IVUS the circumflex, okay, and this is the IVUS of the circumflex right here. trying to see, to understand the ostium. Where is the left main ostium? Where is the LAD? And again, it just blurts out and comes off into the aorta per se, and I'm not able to have a good visualization of the left main ostium itself. So I see the calcium and the circumflex. So I decided I'm just going to shockwave the circumflex right now, and we did extra pulses, more pulses focusing on the ostium of the circumflex. And then I still can't get a wire, that's still a problem, so I decided to put an occlusion balloon in the circumflex and took my Xion wire and decided to hopefully knuckle into the LAD, and that's me floundering around there trying to eventually enter the LAD, and the wire goes into the LAD. And this is where honestly I was so happy the impeller was in place, because if you remember, this is a left dominant system and I just occluded it with a balloon to do this. But this was the crucial point of this. And Xion wire is the wire I like to do when I'm doing this knuckle technique with the occlusion balloon. And now, after that, I'm finally trying to get pictures of the LAD, and the LAD has a big tortuosity here, and I'm not able to deliver anything over this little bend here. And I IVUS the LAD also, and I'm still not able to understand the ostium. It appears to me that this is a dual ostium situation. And this is the IVUS of the LAD again, and you can see the calcium there, and the tortuosity, and the IVUS would go only proximal to that little bend. And we tried it 3 times and with a guide extension, but just could not do it. So again, there you go. That's your ostium, and then you see the second wire, but it's in space. It's not truly in the left vein, and you get into the aorta. So I'm still trying to figure out what strategy I should use here to treat this left main ostium. And now we use the guide extension catheter, dealt with the guide extension catheter, stent that LAD, and I decided to do simultaneous kissing stents with 1 wire, because I thought if I have to do any sort of DK crush or cool out, I will have to swap wires, and there's no way I can lose wire access in any of the vessel, given the amount of time it took me to wire the LAD initially. So we decided to do simultaneous kissing stents and balloon them again without losing wire access. I tried to IVUS after that, and my IVUS catheter actually broke, and my team was like, no, you're not getting a new IVUS now. You're done. And therefore, and this is my final angiographic result. So take-home points. Iliac tortuosity can be a big big issue with single-axis impeller. Intravascular imaging, again and again, I think this is the recurrent theme. And shockwave lithotripsy can be used to modify the plaque at a bifurcation. And that was the true key to success in this case, because there was some sort of a calcium nodule right at the LAD ostium, and I was able to use the circumflex ostium to modify that plaque, and then I was able to wire into it. And sometimes you truly have to walk away with the simplest strategy. With that, thank you very much for giving me this opportunity.